Great. Well, thank you. Selah, thank you for inviting me and this great, exciting meeting. There's so many things changing. I am going to go over imaging devices and how much they have changed what I do, and at the end, followed up with a discussion about a surgical device that I think has been quite helpful as well. If you look at the, hopefully I can go forward here. Imaging devices and what they have their strengths in. Basically, we know that OCT is really good for looking at the cornea and the anterior surface of the iris, the angle, things such as that. But to get a little bit further back, you can go with the UBM to really look at the ciliary body, things such as that. And if you need to see the lens itself and the zonule, you need more ultra-high frequency ultrasound to be able to see that. So the depth of the image is based on what device you're using. Now, the swept source OCTs have just come out. We have one at KSA. We've been using it now for several months. And I've worked with all these companies over the years and watched them help develop their technologies. The advantage of swept source is it gives you the ability to create a 3D reconstruction of things you look at. Now, ultrasound, you know, many of us are familiar with this, and they have these probes that have a nice little water chamber on the front of it now, so you can put it on patients' eyes and not have to have the water bath like we used to have to do. So I think this works well in the clinical situation to be able to use something such as that to get imaging with the ultrasound. Now, things that the imaging devices can really help us with is determining what's going on with the size and shapes of things within the eye, especially in the anterior segment, and it can help us look through cloudy cornea inside of the eye to get some ideas. So things we know about the eye, the volume and the space in the front of the eye predicates what happens sometimes related to glaucoma, especially, such as narrow angles. But it can also play a role in what happens with our effective lens position for deciding with cataract surgery, or looking at issues related to IOLs and where they've been placed within the eye. If you look at what causes angle closure, we've learned a lot from our imaging devices, and Dave Friedman at Wilmer has done a lot in this regard, taking a look at the parameters we can measure, axial length, the lens size, the anterior chamber depth, and how thick the iris is, and what does that all seem to play out in making angle closure occur. In the physical aspects of the eye, we definitely know that the lens, the thicker it is, the more it pushes forward, and that seems to play a role. There's a lot of papers that have looked at that and described it. We also know that the anterior chamber depth, which is related to the zonule lens position and also what's happened with the ciliary body and how it's rotated. And if you have a shallow or a smaller anterior chamber depth, then that's one that tends to have more higher incidence of narrow angles. And then we do know that the arc across the cornea, how much space is there in the front of the eye? Because if it's a smaller, tight cornea versus a big bowing one, you have less space up there, so there's a higher incidence of getting some narrow angles with these patients. So looking at the posterior corneal arc width is good, and looking at the curvature of the lens and the lens vault gives you some ideas what's going on with that. So now let's transition into the imaging and how we look at these things specifically. And you know, here's an example of somebody who had just a thick iris without a lot of lens vault and with a pretty robust corneal arc length, but it was a thick iris that seemed to be causing, and this image was done with the Visante, which is one of our predecessor with the, it's not a swept source, but it's a standard type of OCT, the time domain. Now here, if you suspect somebody has some rotational issues and that there's iris plateau present, this is where I think UBM can be very helpful, because you can actually see the ciliary processes, as you see in this one here, rotated anteriorly, which is causing the iris plateau and the mechanism of the angle closure. And here it is on another, this is another one of the high-resolution images, and how you can really see the whole thing laid out and get an idea that this person has this problem because of what's going on with the ciliary body. Here's an example of high-resolution ultrasound and how it can give you a big picture of the front of the eye, because it even goes back into the lens itself, so you can see the lens volume, you can look at the iris and how it's shaped, you can look at the sulcus, you can see what the cornea is doing. You can get one image with this and get a much better idea of the exact mechanism of the angle closure for a given individual. Now, moving into OCTs, I think that Here's a great example of one of the KSA images, and you can see on the, see where the pointer is here. On this line right here, that shows you the horizontal axis, which is what we're looking across here. You can rotate this, as I'll show you later. But here you can see that the lens is vaulted forward some, but the iris itself is quite thick, and this is creating a very narrow space in the angle, but yet there's no true angle closure. So this is somebody that we can go ahead and continue to observe. The question is, would a PI help in this indication? Probably not. So you can look at these people and get an idea, and here's the three-dimensional remodeling that occurs with the swept sources. And so you can take a look around the eye and get an idea what the whole overall angle looks like with that. Can you advance that one? It's stuck. Thanks. And then this is somebody who has, again, mostly a thick iris, a little bit different configuration, but you know, as you look at this, you can size up if it's going to help you to do a laser iridotomy or not. And I found that's quite helpful. Other things you can use the ultrasound for is to look at the space up in the front of the eye, the sulcus to sulcus if you're considering ICLs, and IOL problems that you have, especially if they're a little more posterior. The OCT has some help with the IOL issues, but here's an example of somebody I did a number of years ago that had problems with dysphotopsia associated with AMO lens that we put in a elastomide lens in front of it, and it got rid of the dysphotopsias. But you can see the lens in its position within the sulcus quite clearly and how it ends up helping out the patient. Now here's an example of the swept source OCT, and this patient came in with angle closure after having had cataract surgery with a sulcus-based lens. And here you can actually see the haptics right here, right over there. But you can't see much further back, you know, to actually see the lens position itself as you can with ultrasound. But nonetheless, we were able to pin down the exact diagnosis of why this person has angle closure. So what we did for this case, we explanted the IOL, the glaucoma went away. You know, so you can make precise diagnoses with the help of the technology. So here's somebody that was having some astigmatism. You can see the pupils peak there, a little bit temporal. And we were able to look at the wound margin itself with this, which I sometimes have found helpful, especially somebody like with Hobbs stria. Here you can see the stria coming off the endothelium. And you get great imaging with a lot of these anterior segment devices. Here's somebody who had a cloudy cornea, as you can see right up in here, and we couldn't really visualize in there, but yet with the swept source, you're able to see that there is a mass up in there, which is epithelial ingrowth, and made a decision to proceed ahead with surgery in this individual based on that. The other thing that I think it's quite helpful for is imaging outflow. And as some of you heard me talk about yesterday, one of the things we know that Murray Johnstone has clearly described is that aqueous goes out of the eye in a pulsatile manner. The trabecular meshwork works like a trampoline. It goes out and it pushes the aqueous into the canalish slim and pulses out the aqueous. Now, we are looking for a way of imaging the canal with MIGS procedures, especially like the eye stent and the hydrous procedure, which are trabecular bypass procedures. And if we can find areas where we feel the canal is pretty well dilated, we might want to target that. The problem is if it's a pulsatile action, you can't really catch it all the time. So what we're able to do with the new swept source is, and you'll notice that these arrows right here are rotated just a little bit. So it's like about 2 clock hours difference between them. And with doing that, you can actually look around the canal and follow the canal. So you can see the canal here, canal there, you can see it over here and there. You can actually rotate it after you've taken the image and notice where it's dilated bigger. So I've been able to look at these for people that we're targeting with the eye stents and been able to see it, which I think is helpful. So the next technology thing that I think has really helped me with resident teaching especially, which we use in Colorado a lot, was using the express technique for that. And I wanted to spend just a few minutes on that going through it because I think it was quite helpful. The express basically what it does, and Abdullah Naki did a great job of talking about this yesterday. I just thought I wanted to highlight it again one more time to say that what it really achieves is a controlled fistula that helps prevent flat anterior chambers. It avoids an iridotomy, and there seems to be less inflammation associated with them. So basically you do a peritomy first. The next thing that you do is create your scleral flap. You want it to be big enough so you can keep the edge of the express covered. And usually we'll make this flap on the order of about 3.5 by 3.5 millimeters. And I'd like to thank Ike Ahmed for providing this video for me to use here today. But this is a nice dissection he's done anteriorly there to get good exposure up past the blue zone. And then once you've created a nice flap, we're able to go ahead and go in. If you can advance the next slide, please. And then once we go in, the whole key with making your incision is to keep the blade, and you can use a small MVR or a 25 to a 27 gauge needle, and keep it flat with the iris plane, and go in and enter, so you're just entering right above the iris to get into the anterior chamber. This creates the ability to get the implant in position so it'll hold in a nice place in the mid-anterior chamber, not touch the iris, not hit the cornea. And that's key with this when you're implanting them. Next slide, please. And one more slide. Thanks. Back one, if you could. Anyway, the handpiece is got a little button on it that you push. So here, once you get the device ready, you lift up the flap, come up to the edge of the opening you've made, turn it 90 degrees to the opening, push the implant into the eye, and then you turn it into position so it locks into place. And there you can see the actual hook on it that holds it from coming back out of the anterior chamber and to keep it positioned. And there's the handpiece itself, and you can see how when you push that, it releases the device and allows it to stay in the fistula that you've created. So here we're going to go in, and he's going to turn it 90 degrees to be able to get it to go in through the opening into the anterior chamber. And once it's in place, he'll turn, and after it's turned, it's left into position where you can check the flow through the device after that's put into place. Next slide, if you would. And then here, I think that's the same one. One more slide forward. One more forward. Thank you. So once it's in place, you check the flow and make sure that it's got some good leakage. The next slide, please. And then after that, put in sutures. And usually you want to make the sutures what I call moderately tight, so it's enough so you have some flow. Decide if you want to use an antimetabolite, then close up your conjunctiva. And what this allows you to achieve is a controlled fistula right after the procedure, and it helps prevent the flat anterior chambers. And I do think it has its place, especially in teaching programs. I found it's quite helpful to use when people are learning how to control the flow through trabeculectomy. So that's one technology that I think has been quite helpful surgically, and I just wanted to finish with that. And thank you. Thanks.
Thank you.